Hello everyone, welcome to the review lecture for the second basic exam practice test. This lecture is set up in a very similar way to how the first one was. There are two separate PowerPoint presentations and they're posted to YouTube just because the file sizes are too big. So please watch and enjoy, and I hope that you get something out of it. So the overview. So 9 out of the 13 people taking the basic exam took this test. And the good news is that everybody who took both tests, that was 8 of you, improved their scores from the first to the second. So that's great. I'm really happy about that. It means you guys are studying and progressing really nicely. The first test average was 134 points out of 200. The second test average was 142 points out of 200. And the questions that are in this presentation that I'm reviewing are questions where at least half of you missed the answer. If you have any other questions, please don't hesitate to contact me or anybody else in the department, or talk with each other. And I'm feeling really good about the efforts here. I'm really happy. All right, so here's our first question on the great radicular artery. The question was a little bit tricky because they didn't leave out they left out the key word, which is Adamkowitz. So the full name is the great radicular artery of Adamkowitz that they were talking about. The patient just had an open AAA repair, and they woke up with paraplegia with preserved proprioceptive sensory function, and they want to know which of the arteries listed was interrupted. So key points about the great radicular artery of Adamkowitz is that it originates between T5 to T12. It's the primary blood supply of the anterior portion of the spinal cord. The anterior spinal cord is more prone to ischemia than the posterior portion, because the posterior portion is supplied by 2 arteries. So what anterior spinal cord syndrome looks like is a loss of motor function below the level of the lesion, loss of pain and temperature sensation, and you retain your proprioceptive, vibratory, and pressure sensation. This is just a little image to the side here about where the ischemia occurs in the spinal cord. Right, our next question is about how the cerebral autoregulation curve shifts in chronic hypertension. So as I'm sure most of you know, normal cerebral autoregulation is intact between maps of 60 to 160 millimeters of mercury. And essentially what that means is the flat portion of the graph here means that cerebral blood flow really doesn't change between pressures between 60 and 160. When it goes below 60, perfusion tends to fall off. When it goes above 160, perfusion tends to go higher than what the brain needs. And the key point is that chronic hypertension shifts this curve over to the right. So rather than 60 to 160, somebody who is a chronic hypertensive may have a cerebral autoregulation curve that's higher, such as 70 to 170, or even higher, 75 to 175. This is important in taking care of patients because somebody with chronic hypertension and a blood pressure of 65 may not be perfusing their brain as a healthier person would who's not hypertensive. All right, our next topic is factors influencing FRC. So FRC stands for functional residual capacity. The definition is expiratory reserve volume plus residual volume. This is a nice picture over to the right, sort of defining some of the volumes and capacities that are within the lung. Volume refers to just one portion of the lung, while capacity refers to 2 or more volumes. And functional residual capacity is the expiratory capacity plus the residual capacity, expiratory reserve volume plus residual volume. So some things that decrease FRC, obesity decreases FRC because of the weight on the chest pushing down on the lung tissue. Females tend to have a slightly lower FRC than males, about 10%. Posture changes FRC, so when you're supine or prone, your FRC is lower than if you're upright. And then restrictive lung disease also decreases FRC. I think the key aspect of this question was that age really has no influence on FRC. It's about 30 cc's per kilogram in both adults and children. And by contrast, oftentimes something that they'll ask you about is closing capacity in aging people. Closing capacity is the volume at which small airways start to collapse, which leads to hypoxemia, and this tends to decrease with age after age 40. All right, this question refers to dead space and the various factors that contribute to dead space. So what is dead space? It's the part of the lung and tracheobronchial tree that don't participate in gas exchange, the part that is ventilated but not perfused. There are several factors that increase dead space, that is upright posture versus supine posture. Neck extension, this formatting's a little off, but increased age also increases dead space. Positive pressure ventilation, pulmonary embolism, which makes sense, that the blocked blood flow creates lung tissue that receives ventilation but not perfusion. And hypotension and emphysema all tend to increase dead space. By contrast, factors that decrease dead space are the supine position, neck flexion. You can think about this because as you move your chin toward your chest, the nasopharynx tends to be scrunched and decreased in volume, which is part of the tracheobronchial tree that is perfused but doesn't participate in gas exchange. This question also referred to an artificial airway decreasing dead space, and how this works, if you think about it, is that when you place an endotracheal tube and blow up the balloon, just the endotracheal tube becomes dead space, and it eliminates the entire volume of the trachea. So this then decreases the amount of dead space that you have. All right, this question asked you to calculate the time to desaturation after apnea with induction of anesthesia. So after apnea is induced, patients tend to remain oxygenated by the gas that is contained in the FRC. This acts as a bit of a reservoir that allows patients to prevent desaturation. So they give you a whole bunch of numbers in this question. They give you a weight, they give you the amount of gas used per kilo per minute, so 3.5 cc's per kilo per minute, which is an average resting oxygen usage. And if you multiply these, you get that the patient uses 245 cc's per minute of oxygen. So if the FRC is 2,400 cc's, and in this is filled with room air, which is 21%, that means that only 500 cc's of that air is pure oxygen. So 500 cc's divided by 245 cc's per minute is about 2 minutes or 120 seconds. And so this question, this concept really explains why pre-oxygenation is so important. So when we have patients breathe 100% oxygen for an extended period of time, it fills up that entire FRC with oxygen. So if the same patient was breathing 100% oxygen, they would have 2,400 cc's of oxygen in the FRC. And if they use 245 cc's per minute of oxygen, they would almost have 10 minutes until a desaturation rather than 2 minutes. So this is why pre-oxygenation is super important. All right, cardiac output to organs. So this question was a bit tricky. The correct answer was that the lungs receive the greatest proportion of cardiac output. But here are some of the other amounts of blood that each of the organs get. So the heart muscle itself really only gets about 4 to 5% of the cardiac output through the coronary arteries. Skin, by comparison gets about the same amount, 4 to 5%. The liver gets 6%, the brain gets about 15%, skeletal muscle gets a similar amount to the brain, and then the kidneys and the GI system get the highest proportion, other than the lungs. So all the blood from ejected out of the right ventricle goes through lungs and does participate in gas exchange to help support that tissue. So the lungs, by definition, get 100% of the cardiac output. So this, like I said, was a bit of a trick question. All right, our next question is pulse pressure variables. So what is pulse pressure? It's systolic pressure minus diastolic pressure. And this value is indirectly proportional to arterial compliance. And what that means is that the stiffer the arteries are, the higher the pulse pressure that you'll see, and the more compliant the arteries are, the less stiff, the lower the pulse pressure. So as we age, arteries become more stiff and therefore less compliant, and so pulse pressure will increase. All right, this question tested pulmonary artery catheter pressures and what normal pressures are measured by pulmonary artery catheters in the various parts of the heart. So normal values for right-sided pressures, our central venous pressures are somewhere between 5 to 12 is considered normal. And the tracing that you see is the normal right atrial pressure tracing that you all know so well, that we've reviewed quite a bit. The right ventricular pressure, as the pulmonary artery catheter is advanced from the right atrium into the right ventricle, is normally about 25 over 5. Now, as you float the swan and it goes beyond the pulmonic valve, there's a characteristic step up. It's called a diastolic step up, so that the systolic pressures are similar in both the PA and the RV, but the diastolic pressure in the PA is somewhat higher. So normal PA pressure is about 25 over 10, and that is how you know that the pulmonary artery catheter is correctly placed. When you blow up the balloon, to get an occlusion pressure, that is somewhere normally between 6 and 12, and obviously can change with various pathology. All right, our next question is about morphine metabolism. So there are three main metabolites, three main molecules that morphine is broken down into. They are 3-morphine glucuronide, 6-morphine glucuronide, and creatively, morphine 3,6-diglucuronide. The last, the 3,6, is a very, very minor metabolite. It's made in very small amounts. Morphine 3-glucuronide is a major metabolite. It's what most of morphine is broken down into, but thankfully this is an inactive metabolite. The one of clinical significance is morphine 6-glucuronide. This is also a major metabolite. About 10% of morphine is broken down into this one, and this molecule itself is about twice as potent as morphine. And the problem can occur when patients who have renal failure cannot eliminate this metabolite, morphine 6-glucuronide, in the urine, and when it accumulates, it can become clinically significant. All right, so our next topic is actually the next couple of slides, because this is a topic that's easily confused, but ultimately once you can wrap your head around it, it's not too hard to get a hold of. So the ionization of weak bases. This is very important because it applies to many different types of drugs, the most important of which are local anesthetics. And what we think about usually with this topic is with local anesthetics. So there are really two forms that you can see using this picture over on the right. There is an ionized form and a non-ionized form. The ionized form has a hard time passing freely through the lipid membrane, and the non-ionized form has a much easier time moving back and forth. So how do these two forms transform back and forth? So it is dependent on both the pH of the environment that the drug is in, as well as the pKa of the drug itself. And that's just a characteristic of each drug. So the drug is in the ionized form, which doesn't pass freely back and forth over lipid membranes when the pKa is higher than the environment. What that means is that there's more H+ floating around in the environment. It's a comparatively acidic environment, so there's more H+ to bind to a base, and this essentially makes it less lipid soluble and causes a slower onset of action. So if you think about bupivacaine that has a pKa up in the 9 range and physiologic pH is in the 7 range, that makes sense that more would exist in the ionized form. Now contrast that to a different drug. When the pKa is lower than the environment, or approximately equal, there's less H+ floating around in the environment to bind to the weak base. So more is in the unionized form, the B without an H+ form. This allows the drug to be more lipid soluble, it passes easier through the lipid membrane, and therefore has a faster onset of action. So we can think about lidocaine for this example. Lidocaine's pKa is similar to physiologic pH, so there's approximately half unionized form and half ionized form, and therefore it's a quicker onset of action to bupivacaine. So take a look at this slide, think about this for a minute. It definitely will appear on your exam at least once in one form or another, and really wrap your head around this one. So now contrast this question to the last question. It's the same sort of topic, but instead of talking about weak bases, we're talking about weak acids. So the same ideas hold true. So phenobarbital is a weak acid, as are all barbiturates, and instead of how bases are set up, the protonated form is non-ionized, and the unprotonated form is ionized, which is the opposite of weak bases. So by alkalinizing the urine, it will actually increase the amount of drug that's urinated out of the system. You can come over here and look at the image. So physiologic pH in the blood is 7.4, and the urine has a slightly lower pH, which provides more free-floating protons around, which would bind to this weak acid and create a non-ionized form. By alkalinizing the urine, you're making it more similar to blood pH, and so therefore more drug would be trapped in the urine and urinated out by alkalinizing the urine. All right, our next topic is sensory evoked potentials. So this is a very popular question topic on exams. There are 4 main types of sensory evoked potentials to know about. Somatosensory evoked potentials, which monitors the dorsal or posterior columns of the spinal cord. Motor evoked potentials, which monitors the ventral or anterior column of the spinal cord. Brainstem auditory evoked potentials, which monitors the hearing pathways. And visual evoked potentials, which monitors the visual pathways. Now, each of these are sensitive in a variable sort of way to the anesthetics that we give. So the most sensitive to anesthetics are the visual evoked potentials, which makes sense to me. Whenever we give an anesthetic, the eyes close, we start to drift off to sleep, and so the visual evoked potentials are the ones that go first. The next on the list are motor evoked potentials, and I remember this because when doing spine cases, whenever the nerve monitoring people are monitoring both motors and sensories, that is when we have to use full TIVA. Any gas at all would tend to make the motor evoked potentials worse. So those are the next in line in terms of sensitivity. The SSEPs are somewhat resistant to our anesthetics, When they're only monitoring SSEPs in the spine cases, they'll often tell us that it's okay to use half a mac of gas. And that's because the SSEPs are somewhat resistant to our gases. The least resistant are the brainstem auditory evoked potentials. And this makes sense to me also because sometimes patients will report hearing, in the recovery area, that they'll report hearing things that were going on in the operating room, even though they weren't awake or able to see what was going on, which makes sense because the brainstem auditory evoked potentials are the most resistant to our anesthetics. So memorize this order, and you'll definitely get one question right on the test. So there's a question here about how etomidate affects the central nervous system and the few variables in particular. So CMRO2, or cerebral metabolic oxygen consumption, will decrease with a dose of etomidate. And this makes sense. The brain goes to sleep and uses less oxygen. Because of this, the cerebral blood flow will decrease as well. Now, the question also asked about cerebral perfusion pressure and how that's affected. So since cerebral perfusion pressure is MAP minus ICP, and MAP with a dose of etomidate is often maintained, a decrease in CMRO2 and a decrease in cerebral blood flow will lead to a decrease in ICP. So a maintained MAP minus a smaller ICP will actually increase the cerebral perfusion pressure. So therefore, with etomidate, the cerebral perfusion pressure will tend to increase. I believe most of you said decrease across the board, but this is the explanation for why the cerebral perfusion pressure will actually increase. All right, our next topic has to do with the cardiovascular effects of ketamine. So in general, ketamine produces a stimulatory effect on the cardiovascular system. So MAPs are increased, cardiac output is increased, systemic vascular resistance is increased, PA pressures are increased, everything is increased, right atrial pressure, stroke work. This question tested whether left atrial pressure also increased, and here we see that there's often no change. This is due to the increase in SVR and increased LV stroke work. Oftentimes the left atrial pressure will stay the same just because forward flow is often more challenging. All right. Our next question here is additives to local anesthetics for peripheral blocks. So this is going back a few minutes, another spin-off on the ionization of local anesthetics in various pH environments. So there are several things that are routinely added to local anesthetics when peripheral blocks are given. There are alpha-1 agonists, which most commonly are epinephrine as well as phenylephrine. These promote vasoconstriction and tend to reduce uptake systemically of local anesthetics, so therefore these prolong the duration of a block. Alpha-2 agonists tend to work at the dorsal horn of the spinal cord. These are clonidine and Precedex. Clonidine is often added to block solutions. These act at the dorsal horn of the spinal cord and prolong blocks. Steroids have been described to add to block solution. This mechanism is a little bit unclear, but they've also been shown to increase the duration of the block. Now, bicarb, when added to lidocaine, has been shown that it raises the pH of the environment. Therefore, it increases the unionized form, and therefore gives a faster onset of action. Adding bicarb to a solution doesn't necessarily increase the duration of the block, but because it encourages a more unionized form, there will be faster onset of action. All right, our next question is about low molecular weight heparin and the characteristics of this drug. So, as all heparins do, they bind to antithrombin 3 and activate the antithrombin 3 complex. And then this inactivates the action of factor 10A. There are some advantages of low molecular weight heparin over unfractionated heparin. It tends to have a greater bioavailability when given by the sub-Q route. There's a prolonged duration of action, so you have to take fewer injections. Low molecular weight heparin tends to be 6 to 8 hours, and low molecular weight heparin tends to be 12 to 24 hours, depending on the dose. There's no need for lab monitoring with this medication, and there tend to be fewer side effects, especially with HIT. Now, there are some disadvantages. Low molecular weight heparin is incompletely reversed with protamine, whereas unfractionated heparin is more completely reversed. And then, since there's a longer duration of action of low molecular weight heparin, it is a bit harder to titrate. Okay, this is the end of the first presentation. Please continue on to the second part of the presentation. Thank you.